like to say greetings. Like to say greetings to everyone. My name is Ray Shoemaker. I am with the National Panhellenic Council of North Mississippi. I would first like to welcome you to this Lunch and Learn via Zoom. I'd also like to thank you for spending your time with us, finding out a little bit about what your grandparents may have not known. Hopefully, you can leave this Lunch and Learn and take information that will benefit your family, your friends, and your loved ones. Again, thank you for coming on with us today. We look forward to sharing vital information as it relates to what your grandparents didn't know about cancer, and to add to that tagline, what we can do going forward with information that we are aware of. Thank you. So I'd like to talk to you a little bit about our partners presented this working together today to make this Lunch and Learn a great event. First and foremost, as you can see, there are three partners. The first partner, the Omega Psi Phi Fraternity. A little bit about Omega Psi Phi Fraternity. It was established in November 17, 1911. This fraternal blueprint has welcomed over 250,000 members with a mind and spirit of service to mankind. As a state organization, Omega Psi Phi Fraternity represents over 1,500 members with 21 graduate and 9 undergraduate chapters. The organization focuses on building relationships through target programs while hosting a variety of service projects, yet many of those projects are around health, education, and awareness. That is the reason that Omega is so proud to be a partner in this discussion today. The National Panhellenic Council, affectionately known as the Divine Nine, is an organization that was founded in 1930 at Howard University. And those 9 organizations are our 9 African American Greek fraternities and sororities with the purpose of fostering cooperative actions of its members in dealings of matters of mutual concern. At our state level, in terms of NPACs, we have NPAC of North Mississippi, and we have our other National Panhellenic Councils of Mississippi, Metro Jackson, Mississippi, Golden Triangle, Greater Greenville, the Meridian, DeSoto, and Gulf Coast councils as part of this project. Force is a force to be reckoned with, of course. Facing our risk of cancer empowered is what FORCE stands for. FORCE is the preeminent voice for the hereditary cancer community, serving millions of high-risk individuals nationwide. As an advocate, leader, and subject matter expert, FORCE strives to ensure that individuals and families facing hereditary cancer are represented. Better the landscape by working to guarantee that every person with a risk of cancer can have access to recommended treatment. Ladies and gentlemen, those are our partners, and we're so proud to be in their presence today. Our speakers, as I've stated, I am Ray Shoemaker. I'm a member of National Panhellenic Council of North Mississippi. I serve as the president for that organization and a member of the Omega Psi Phi Fraternity, whereas both organizations, our interest is in making our communities better, where we're focused on health outcomes centered around many of our projects are related to cancer issues throughout our communities statewide. Ms. Veranda Hobbs with FORCE is the FORCE Partnership Strategy Manager and a cancer provider. Ms. Lenora Johnson, FORCE Board President, colorectal and endometrial cancer survivor. Mr. Nottingham, one of our speakers today as well, is the CEO of JNOT, GTT, colorectal survivor and FORCE volunteer. Ms. Juanita Rogers, FORCE Vice President of Health Education and Communication. And I'd like to highlight that we also have a genetics expert with us today, Ms. Angela Trepanier, will also be sharing information with us as she serves as a member of the advisory.
Well, Ray, I guess this is where I come in. And
Yes.
I want to thank you for that introduction. And good morning and good afternoon to those of you out there. I'd like to again begin with that reintroduction of FORCE, which actually stands for Facing Our Risk of Cancer Empowered. We are a national nonprofit organization funded in 1999 and devoted to improving lives of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people and families with inherited gene mutations linked to cancer. We accomplish this through our education, support, advocacy, and research efforts. I'd also like to share with you just a snippet of my story. And it begins with just sharing that my name itself was just an accidental name. You see, my mom wanted to name me Winona, which is Native American for firstborn, but the hospital spelled it wrong, and the name Winora was instead put on my birth certificate. The funny part about this is that my mom told us for years that we had Native American in our family and that it was part of our heritage. Years later, upon completing a genetic test for myself, I found out that I actually had 0.001 Native American ancestry, but close to 20% Irish ancestry. You know, I tell this story because what I really wished my mom would have shared with me is that my grandfather passed away from colorectal cancer at the age of 38. And knowing this information might have changed the trajectory of my cancer story that you will hear about later. Next slide. So here are the topics we plan to cover today. First is provide facts and dispel myths about hereditary cancer and genetic testing. Discuss high-level information about genetic counseling and testing. Share personal stories, highlight force resources, and finally wrap it up with a question and answer discussion. Next slide. And just a few housekeeping items. If you have comments or questions, please feel free to type them in the chat. And keep in mind that we will have time for questions and answers after the presentation itself. So next slide, please. What we are going to do is make this interactive, and we're going to start with a quick poll. And this particular poll here, if you could just respond back by either putting A, B, C, D, or E. And the question is, including yourself, going back 2 generations, how many people in your family have cancer? A is 0, B is 1 or 2, C is 3 to 5, and D is more than 5. Or E, I don't know my family's medical history. Wow, I see a lot of answers in here. Really, really appreciate that response. These responses are very helpful for us too, because it helps us to really understand that cancer affects more of us than we really realize, and especially those close to us, our family members. And so I'll give this a few more seconds here for those who are still submitting their answers. Again, we appreciate that. It's greatly appreciated and helps us continue the work that we do. And so as we go into this next slide, I'm going to hand this portion off actually to Juanita, and she'll further define what we do.
Thank you so much, Honora, and thank you all. Good afternoon. We appreciate your responses. We are going to have a couple of polling questions sprinkled throughout the presentation. It's not to overwhelm you, but just to kind of share some of the important points that we want you to take home by the end of today. So first, we're just going to start off with some definitions and an overview of the impact of hereditary cancer, just to have the same starting point for everyone, because some of this might be new, and that's okay. So the first definition is going to be inherited mutations. And those are changes in genes that can be passed on from parents to children. So generation to generation, that DNA that makes us all up, that gets passed down. And hereditary cancers are cancers that are caused by an inherited mutation. To give a little bit more detail, some inherited mutations can increase an individual's risk for cancer. And additionally, the inherited mutations can cause cancer to run in families. And that's why we're here today and stressing the importance of sharing your family medical history to make better decisions and to be more informed. So overall, cancer is common in the United States. There are 17 million cancer survivors in this country. So most cancers, it's important to know, although cancer is common, most cancers are not hereditary. And that's what we see here in this pie chart. So 90% of cancers that are known are going to be caused by various factors, including age, environment, and lifestyle choices. But that 10% is going to be hereditary cancers. And that's what we see when we say it's caused by an inherited mutation, and that's one that runs in the family. That is the 10% of cancers that are known in the United States. So it might make you wonder, well, why is the 10% so important if it's a smaller piece of that pie that we saw? Well, we want to make sure that people know that there is a higher risk, higher lifetime risk for being diagnosed with cancer. There is the knowledge and the understanding that the risk can be passed down through generations. Unfortunately, most people are also unaware of their risk. And not to mention, there are barriers already in our healthcare system. But when we have barriers to access to genetic services, it widens those disparities. And we're going to talk a little bit more about that in the next couple of slides. So when we mention disparities in hereditary cancer, we see that hereditary cancers are found in families of all racial and ethnic groups, but there are certain groups within our country that are less likely to be referred for genetic services or preventive services. And so it's important that people discuss their family medical history, know and understand their family medical history, and also be aware of the resources that are available to them and the steps that they can take. And we will be able to share that today. So really quickly, I want to talk about the most common hereditary cancers. And what you see here are 4 of the most common ones: breast cancer, colorectal, endometrial, and prostate. And what people might not know is that not only are these the most common hereditary cancers, but these are also the cancers that have the largest disparities amongst differing ethnic groups. So breast cancer, colorectal, endometrial, prostate, these are ones where it is important to reinforce that you know the family medical history, especially if these cancers have been within your family. So we have one quick question, and we want to know, how familiar are you with genetic testing for hereditary cancer risk? If you're not familiar at all with it, you'll put a 1. If you're somewhat familiar, you'll put a 2. And if you're very familiar, you'll put a 3. Thank you. You see some answers coming in. A lot of 2s, couple of 3s, couple of 1s. Give it a couple more seconds for people to respond. And this is helpful because we're going to go into the next section of our presentation. And Angie, our genetics expert, is going to share a little bit more about these details that will be helpful for you and your family. So Angie, I'll go ahead and pass it on to you.
Okay, thank you, Anita. Can everybody hear me okay? Great, okay. As Manita said, I'm going to talk a little bit about genetic counseling and testing and the options related to that and what helps us know when somebody might benefit from genetic counseling and testing for hereditary cancer. In genetic testing, when we're talking about hereditary cancer, some of you, if you know people who have had cancer and they've had genetic testing on the tumor itself, that's different than the type of testing I'm talking about right now, the inherited cancer testing. So this type of testing happens usually on either a blood sample or a saliva sample from a person's mouth. More rarely, we will take a skin biopsy to do testing, but we're looking at the inherited information that person has, the genes they inherited from their parents, to see if there's a change in one of the genes that can be associated with an inherited cancer syndrome or inherited cancer condition. In genetic counseling and testing to see if somebody has an inherited risk of developing cancer are recommended if you or if a close relative, and close relatives are usually your first and second degree relatives, so your parents, your siblings, so your brothers and sisters, your children, aunts and uncles. Sometimes we go out to cousins or grandparents, but it's recommended if any of them have been diagnosed with any of the following. So breast cancer or colon cancer or endometrial cancer before the age of 50. And one of the things we know about hereditary cancers is that they tend to be associated with an earlier age of onset than usual, and that's usually considered before age 50. Now, that doesn't mean that everybody that has cancer before 50 has an inherited form, but it's something that we call a red flag. It's a risk factor. If somebody has a particular type of breast cancer called triple negative breast cancer, that's a characteristic that the pathologist would see in the breast cancer tumor itself. They have an increased risk of hereditary breast and ovarian cancer syndrome, so having an increased risk of hereditary cancer. If somebody develops breast cancer in both breasts and they're separate tumors, so not if they developed it in one breast and it spread, but if they had two separate tumors, that's called bilateral breast cancer. That's a risk factor. Anybody who's had ovarian cancer or pancreatic cancer or male breast cancer, regardless of age, those by themselves, each one of those is a risk factor for hereditary cancer. And again, it doesn't mean that everybody who has those conditions has an inherited form. But for instance, about 20 to 30% of ovarian cancers are inherited. And so if there's any family history of those types of cancers in a first degree relative, so your siblings, your parents, your children, or a second degree relative, your grandparents, aunts and uncles, then that person is eligible for genetic counseling and testing for hereditary cancer. And then finally, metastatic prostate cancer. So that's prostate cancer that's spread beyond the prostate itself. That's a risk factor also just by itself for hereditary cancer. And why might somebody seek out genetic testing to see if a cancer is inherited? Some of the reasons they might do that is that if somebody has genetic testing and finds out that they have a change in a gene that increases the risk of developing certain types of cancer, that gives them information about maybe why they're seeing the family history they see in their family. It might finally give an explanation for why there was certain types of cancers in the family over many generations. It gives that person information about their personal cancer risks. So each one of the genes that we have testing for has a profile in terms of what the risks are associated with having a change in that gene. And that can tell a person and their family members about what cancers they might have an increased risk of developing. And then that tells their doctors what type of screening might be beneficial in those individuals and families. And it also tells them at what age they might want to start that screening. Because since hereditary cancers can occur at an earlier age of onset, usually screening is going to start at an earlier age before it might typically start. And then that information also provides information about cancer risks to relatives. So those relatives may have also inherited that same genetic change. Some will inherit it, some won't. And those who inherit it have an increased risk of developing the cancers associated with that condition. those who didn't inherit it are not at increased risk. So it lets some people know that if they're at increased risk, there's more they need to do for cancer screening and prevention. If somebody didn't inherit it, it tells them that their chances are the same as anybody else in the population for developing cancers. And like I said, that all guides decisions about things like cancer screening. How often? At what age should it start? What types of cancer should there be screening for? For instance, we don't often or offer screening for certain types of cancers unless there's a family history. Now, everybody gets offered screening for breast cancer. Anybody who has breast tissue gets offered screening. But if they have hereditary breast cancer, it starts at an earlier age, and they use a couple of different methods to screen. It gives people an option to think about risk reduction strategies, meaning that if somebody is at higher risk for breast cancer, for instance, they can decide whether they might want to have their breast tissue removed before cancer develops to prevent cancer from developing. Not a decision that everybody makes, but it's an option that people have. Genetic testing can guide cancer treatment. For some people, knowing what type of gene change they have can help determine what kind of chemotherapy might be the best option. And then also helps people know about childbearing and fertility options. Sometimes in people who have had strong family histories of cancer with a genetic cause of that cancer, they might decide whether they can use certain types of fertility testing to see whether or not those children would have that risk, and only then decide to have children that don't have that risk. So there's a lot of things that you can use that information for. And there's, it's up to everybody how they use that information. And genetic counseling, so that's when someone like me, a genetic counselor, sits down and talks to a person or their family about the risk of hereditary cancer, the genetic testing options available, and the benefits and the risks and the limitations of genetic testing. And then we also talk about screening options, whether or not somebody has that testing. And that can happen before genetic counseling can happen before somebody's had genetic testing. So we go through all of that information in that case. Or sometimes a genetic counselor will see somebody after the testing has already been done. And the genetic counseling is used to explain that test result in the context of the family history, and also to talk about what it means for the patient and what it means for their family. And so depending on when a person has genetic counseling, we may be talking about whether it's something, genetic testing is something they want to do, or if it's after genetic counseling, we're talking about now that you have, or after genetic testing, we're talking about now that you have this information, what can you do about it, and how should you let your family know about this information? But in either way, someone will talk to you about medical options. They'll interpret the results for you so that you know what they mean. They'll help you think about ways to communicate with your family, and they'll talk about your family history. And as I alluded to, genetic testing can be beneficial, but it can be beneficial at a lot of different times in a person's life, and it really depends on a lot of factors. Genetic testing can be helpful before a diagnosis. If we identify that somebody's at high risk for an inherited syndrome before they've had any cancers, then that helps them get connected with screening, advanced screening, and medical checkups with their doctors, hopefully so that will either prevent cancer or help us detect cancer at an earlier, more treatable stage. So that's ideal, but sometimes genetic testing doesn't happen until somebody's newly diagnosed. Maybe there's no family history. Maybe nobody ever took the family history. But if that person has a risk factor for hereditary cancer, they may be offered testing at that moment. And sometimes that can help with decisions about how to treat that cancer. Sometimes testing happens during treatment. Sometimes it happens after treatment. And then sometimes it happens during survivorship. And when it happens is very variable, and it depends on what genetic counseling and testing could do to help that person in their cancer journey if they've had cancer. And it depends on when that person is ready. And I've seen people who have had genetic counseling and not had genetic testing for years, and then they come back when they're ready, to have that genetic testing. So it really is individual for each person. And the goal of genetic counseling and testing is to make sure that everybody makes their own individual decision about what's right for them and their family. And in terms of giving you some information, two of the most common genes associated with hereditary cancer are the BRCA1 and BRCA2 genes, and that just stands for breast cancer 1 and breast cancer 2. And those genes are linked to an increased chance of developing breast cancer, ovarian cancer, pancreatic, and prostate cancer. And that includes breast cancers in males as well. About 1 in 400 people carries a BRCA mutation. If somebody is of Ashkenazi Jewish ancestry, it's 1 in 40. It's higher. There's a founder change in that gene. And so it poses a higher risk of those cancers. And then Lynch syndrome is another set of genes. So Lynch syndrome was named after a physician, Dr. Henry Lynch, who found a number of families who had this constellation of cancers that included colon cancer, uterine cancer, which is also called endometrial cancer, ovarian cancer, prostate cancer, and some others. And he realized that in some families, these cancers clustered together. And again, these cancers occurred at much earlier ages than usual. And so this was named after him, Lynch syndrome. There are about 5 genes that can cause Lynch syndrome. And when you find out that you have a change in one of the genes that causes that condition, it triggers a lot of different screenings to help you identify cancer. Again, hopefully to identify it at an earlier, more treatable stage. And with colon cancer, if you're screening at an earlier age by colonoscopy, you can actually find colon polyps, which are the precursors to actual cancers, and take them out before they become cancer. So it's an opportunity to actually prevent cancer in that case in the family. And so we're going to start with another question. So based on what I told you, true or false, genetic testing is only helpful for people with cancer in their family? Do some falses. Yep, false. Yeah, you all got it. It's definitely false because just age by itself can be a risk factor. And genetic testing is helpful for people with a lot of cancer in the family, but that is not the only indication for genetic counseling and testing. So I am going to turn it over to Verinda, and she's going to share her personal story.
Sorry about that. So now that you're familiar with the basics of genetic counseling and testing, we're going to share some of our personal stories and the ways that hereditary cancer have impacted our lives. Next slide, please. So this is a photo of my father. He's in the center. I'm standing behind him, and my sister Allison is on the right. My sister and I carry the BRCA1 gene mutation, and we believe we inherited the mutation from my father's side of the family. But we will never know for sure because my father refuses to get genetic testing. I think some men want to believe they can't be the one that carries a gene mutation into their family, maybe because they see it as a weakness, or maybe it's a fear of being responsible for passing it to their children. Either way, I think we need to understand and acknowledge it because it's part of our family history now. So my story is about my sisters and my cousins on my father's side. Sometimes cousins can be as close as sisters, sharing secrets and dreams of the future. And sometimes sisters and cousins can also share genetic mutations. Next slide, please. I'm sharing 2 more photos. The photo on the left is my sister Sharon and me as kids. And the photo on the right is of my sister Allison and me taken last summer. In 1993, my sister Sharon found a lump in her breast. She was 27 years old. She mentioned this to her doctor and her gynecologist, and neither of them thought much of it because of her age. Because of this, Sharon received a lot of misinformation from the medical community. Some suggested she rub some vitamin E into the lump. Some advised that the lump would go away after her next period, or they would say, you're too young, you can't have cancer. Well, the lump didn't go away, and finally, my family decided we should seek guidance from specialists. After a whirlwind of activity, scheduling visits and second opinions and biopsies, we were eventually told by an oncologist at Memorial Sloan Kettering that Sharon's lump meant breast cancer and that it was a very aggressive form called triple negative breast cancer. Black women are more likely to develop breast cancer at a younger age than white women, and triple negative breast cancer is more likely to affect Black women under 40. So after my sister's diagnosis and treatment plan was established, she went on to her honeymoon. My sister Allison started college that same September and moved to Harvard as a freshman. Sharon's treatment included a lumpectomy, chemo, and radiation. And during the treatment, she was difficult for her to work and do things. So she moved in with my parents, and I would go by the house after work to visit, doing what I could to support them. Sharon did bounce back and returned to work and her life in Jersey City for almost 4 years. And then the cancer came back, and it came back with a vengeance. It was now metastatic and it spread to her lungs. I often wonder if Sharon's cancer would have been treated more aggressively, or if she would have been given more treatment options if she hadn't been so young, if she hadn't been Black. She died in March of 1998, and she was 32 years old at that time. By 1999, my cousin Cynthia, my dad's niece, had also been diagnosed with triple negative breast cancer. Cynthia's doctor suggested genetic testing because of our family history. And when Cynthia's results came back positive for BRCA1, she really tried to convince me and my sister and her sister to get genetic testing, but I wasn't ready to do that. I continued to do surveillance. I did find a breast surgeon and began going to her regularly. The surgeon suggested that given our family history, my sister and I were both at high risk for cancer, and she strongly suggested genetic testing. She also told me about a procedure, a prophylactic bilateral mastectomy, where they would remove both my breasts even though I didn't have cancer. She introduced me to FORCE and suggested I go to the support meetings where I could meet other people who were going through similar situations. And that was really the best advice that she gave me. I started going to support meetings. I could ask all kinds of questions. I felt supported there, and I soon became a patient advocate volunteer. And much later in 2022, I went to work for FORCE. In the meantime, my sister Cynthia underwent treatment for her cancer. She went through chemo and radiation. When she recuperated enough, she went back to work. But her cancer came back again before she reached her 5-year milestone. The company she worked for was not supportive, didn't help her on her journey. She lost her job, her health insurance, and she ended up declaring bankruptcy to try to save her home. Her sister Valerie was diagnosed with breast cancer about the same time. And in an ironic twist, Valerie went through initial treatment and Cynthia went through her recurrent treatment for a recurrence at the same time. So they were in treatment together, which isn't actually that unusual for family members to have to be both caregiver and patient at the same time. Once Cynthia's cancer was metastatic, she was never referred to a clinical trial. I tried desperately to find more treatment options for her, but without insurance, there wasn't much we could do, and we lost Cynthia in 2012. When Valerie's cancer came back, it was as aggressive as Sharon and Cynthia's tumors had been. Our families were devastated, and I knew I couldn't put off genetic testing any longer. I really wanted to know what my risk was. So my sister Allison and I both had testing, and that's how we found out we carry the BRCA1 gene mutation. Valerie fought back through her recurrence, but ultimately we lost her too. Allison chose to continue surveillance, and I decided to help have the preventive surgeries, a prophylactic mastectomy with reconstruction, and a year later, a procedure to remove my ovaries and fallopian tubes. And that surgery pushed me right into menopause, hot flashes and night sweats. And at the time, I was told that I couldn't do hormone replacement therapy because of my family history of cancer, but things are different now, and hormone replacement therapy is available to help people manage surgical menopause. At the end of the day, evidence suggests that my father most likely passed the BRCA1 gene to me and my sisters, although my sister Sharon, who passed, was never tested. My father's sister probably passed the gene to my cousins. Neither my father or his sister ever developed or tested or developed cancer in their lifetime. My sisters and I don't have children, so this particular line of BRCA1 will end with us. But knowing your family history and receiving genetic counseling where appropriate can be a gift. Valerie has 2 daughters who watched their mom struggle with cancer, and they know they are at risk for an inherited gene mutation. They can choose what to do with that knowledge. They can start screenings and make decisions about their medical care. It's all about being given knowledge and the opportunity to take control over your life. COVID impacted many families in many ways, and at the height of the pandemic, it was difficult for people to get regular screenings for cancer. My sister couldn't continue with some of her screenings during the shutdown. Her appointments were getting canceled or rescheduled. And so Allison was diagnosed with ovarian cancer in 2022. She received and completed her treatment, and I'm thrilled to share that her last scans show no sign of cancer. And I believe really that because my sister knew she was at risk and she was BRCA1 positive, she was being screened, her cancer was found earlier than it would have been had she not been aware of her inherited risk of cancer. I've learned a lot from our family's journey. I know that being a survivor is also hard in its own journey. I learned that knowledge is power and that knowing the risks helped me make decisions that were right for me. It helped me take control of my future. I've learned the importance of patient advocacy, either advocating for yourself or for a loved one. I learned to reach out so I can be both a caregiver to others and to myself. There's always the need to stay vigilant and follow screening guidelines. I learned how hard this experience can be on those you love and on those you lose. I learned how difficult it can be to justify your own medical decisions when you want to control your destiny. And I learned how important it is for me to have support from my spouse and my family during this journey. I learned how important finding an organization like Force can be as I continue this process. There are always family members who just don't understand or don't want to know, and all we can do is try. And I thank you for listening. And now I'll ask Lenora to share her story.
First, Verinda, I just want to say thank you for sharing because I know that's difficult for you. And I'm also happy that you found Force in the meantime to help you through this. You are such a great advocate, and I truly appreciate you and your story. So, a little bit of my story actually begins in 2011. It was after a yearly checkup with my healthcare provider. And this particular yearly checkup included a FIT test, or what they refer to as the fecal swab test, and what today is kind of known as the Cologuard test. This test then led to a colonoscopy and then led to what was supposed to be a minor surgery. And waking up from that surgery by a doctor who would later become my oncologist, stating that you have colon cancer, it's stage 3B, and you've probably had it for 15 years. This diagnosis was followed by the standard care treatment for colorectal cancer, which included a colon resection and 6 months of chemotherapy. And just when I kind of thought I was out of the woods in 2016, I was encouraged by my oncologist to have genetic testing done. And at first, I was a little resistant. I put it off for a couple of months, and finally, and I'm just so glad that we had this really good relationship. My oncologist kept badgering me and asking me to take this genetic test because she just felt that I might be prone to Lynch syndrome. And by this time, I had, of course, found out that my grandfather had passed away from colorectal cancer. My mother herself had passed away from a glioblastoma. And I felt that, you know what, I'm going to listen to my oncologist and take this genetic test. The genetic test did come back positive for Lynch syndrome, having an MSH2 mutation. And something else it told me, it said that I had a 60% chance at that time of getting endometrial cancer. This was valuable information that allowed me to take preventive measures with my health. And so at that time, I opted to have a complete hysterectomy. But upon review of my biopsy, I had the beginning stages of endometrial cancer. Then in the following year, in 2017, I had what was really a small pimple on my backside. I tried several different kind of ways just to kind of get rid of it, and finally decided I needed to take a trip to my dermatologist. I was a little bit more aware of what Lynch syndrome was and some of the signs, and even told her that it could possibly be cancer or cancerous. And she didn't think so, but she went on to remove about 2 inches of basal cell carcinoma from my backside. So for me, 3 times a cancer survivor. This is the value that genetic testing brings, and understanding your risk of hereditary cancer. Because to this day, I'm just determined to be a survivor. If we can go to the next slide, please. So, what makes hereditary cancer different? Some features are younger onset. I was under the age of 50 when I was diagnosed with my first cancer. So I was 44 at the time. Higher lifetime risk. Due to my positive status of Lynch syndrome with an MSH2 mutation, I have a higher risk throughout my lifetime for various cancers. More aggressive. Due to my particular mutation, my cancers are aggressive in nature when found. Different screening, prevention, and treatment options. While I have a mutation, I take care to follow my doctor's recommendations on yearly colorectal cancer screenings and follow up with my other healthcare providers, like my gynecologist and dermatologist, to try and stay one step ahead of future cancer diagnosis. So next, I'd like to maybe hand you off to Junius, who will share with you his cancer story.
Good afternoon. Um, I'm going to share not my story, but my nightmare with you. The young man in the picture is my son. His name is Jeremy Kyle Nottingham. At the time, Jeremy was of the picture. Jeremy was 27 years young. He worked for the Secret Service. He traveled all over the world. My family and I were on vacation in Florida, and Jeremy shared with my wife that when he goes to have bowel movements, he's bleeding. So we're thinking it's hemorrhoids. So we tell Jeremy when he goes back to his field office to go to the doctor, which he does. And then the next day, my wife and I get a call saying that Jeremy has stage 4 colon cancer. So we're looking at each other saying, okay, how are we going to manage this? Well, the next day we get another call saying that the cancer had spread from Jeremy's colon to his liver, and he had stage 4 liver cancer. So in less than 36 hours, our world changed forever. Then we're introduced to a term that we had never been familiarized with before called Lynch syndrome. And we're told, my wife and I and our daughter, that we, the three of us, along with my siblings, we have to go get tested. And we go get tested, and I have the gene. I have a gene that I didn't know anything about that I passed on to our son. Now, going back in time a little bit, January 28th of this year was 30 years ago that my mom passed. My mom was 61 years old when she passed. My mother had ovarian cancer, as did my grandmother, as did my aunts. I had a brother that passed at the age of 50. So there was signs that there was cancer prevalent in our family. And I'm not blaming any doctors, but no one told us or suggested that we go get genetically tested. Jeremy decided that he wanted to come back and live with us, which he did. So we came back and we took care of Jeremy for 2.5 years. And Jeremy fought like heck because he wanted to live. So between taking him to Johns Hopkins and the Cleveland Clinic and Jeremy getting a colonoscopy bag, he fought like heck because he wanted to live. And I don't care how old your child is, you don't want to see your child suffer. We don't want to see that. And Jeremy would turn to me, as many of your children have and will do, turn to you and say, is everything going to be okay? So being the father that I was, I said yes, not knowing whether he was going to be okay or not. So not only did we watch Jeremy suffer and die, I was diagnosed with stage 1 colon cancer, which was removed. And then I was saying to God, well, God, why did I get stage 1 and Jeremy get stage 4? Let's reverse this thing around. Let Jeremy, my prayer was, let Jeremy live and let me die, because I was older. He was young. I wanted him to have his life. So for 2.5 years, Jeremy fought like heck. We took him to every doctor that we knew. Someone mentioned it earlier. I would stay up all night long trying to find clinical trials, and there was nothing out there. Nothing. And Jeremy would say, Dad, it's not fair. You know what? He was right. It wasn't fair. So the takeaway is, there's a number of takeaways. The first is, if there's a history of cancer in your family, have that discussion. Talk about it. and not only talk about it, do something about it. Well, you could say, well, Junius, I go to my general practitioner and he or she says the insurance won't cover it. Don't stop there. Go find a genetic counselor. I'm learning, and I'm still learning that in this process, we have to be advocates. And I'm not knocking any doctors, I'm not knocking the insurance company, but we have to be our own advocates. And I was Jeremy's advocate for him. I set up a nonprofit to honor him. I have a weekly podcast to honor him. So my message to each of you is to know your family history, talk about it, do something about it, and share that with other people. I started off by saying this is a nightmare for me, and it is. And you say, well, why is it a nightmare? Because in the circle of life, a child is not supposed to die before their parent. And then the fact that I live with some degree of guilt that I couldn't control, that I pass it on to Jeremy. So I control what I can control. When I'm not having a good day, I don't say I'm having a good day. It's okay not to be okay. And my prayer had been that God heal Jeremy. And God did heal Jeremy because he took Jeremy out of his pain and misery, and Jeremy's in heaven with the Lord. So those of us who are here on this panel, those of us who are part of this webinar, we have a responsibility now that we know. I didn't know, but now you know, we know, Renora knows, thank God for Force. We have a responsibility to act on the knowledge and information that we know. So I appreciate the opportunity to share with you. I'll post my nonprofit in the chat room. Feel free to follow up with me. I'm still learning. I have a dermatologist. I have a kidney doctor. I have a cardiologist. I see 5 different doctors because, as someone said earlier, once you have cancer, it can come back. I mean, so it's not like it's a one and done thing. Winora knows this very well. It can come back. So you have to constantly be monitored, and that's a whole mental challenge in and of itself. So I appreciate the opportunity to share with you. Again, talk to your family, act on it. If the doctors say no, don't stop there. I'm going to pass it on to Angie. Thanks for listening.
Thank you, Honora and Junius and Brenda, for telling us your experiences. And I hope that all of you who heard their experiences, I hope this helps you if you're thinking about looking into genetic counseling and testing for yourself and your family. And I hope you can see how it can be of tremendous value, even if it can be a hard decision to make. And I also wanted to point out, and I think you might have gotten this from these examples, that inherited mutations affect both men and women. And especially with the breast cancer gene, for a long time, there's been a misconception, even amongst physicians, that if there's hereditary breast and ovarian cancer in the family, it can't get passed on from the father. It can get passed on from the mother or the father. And men, as you've heard, can have cancers related to changes in the breast cancer, quote unquote, gene. And this is an article by Angel Moses, who's a Force volunteer, who had a BRCA2 mutation, one of the hereditary breast cancer mutations, and had breast cancer. And her father developed a metastatic or an aggressive prostate cancer. And she said to his doctors, he needs to have genetic testing. And they said, no, he can't have this. It's not passed on from him. But she prevailed and he had testing, and he definitely did have this as well. So it can come from either side of the family, and it's important to know that. And it's also important to advocate for yourself. If you're worried about something in your family history, then definitely tell your doctor about it. Ask them. If you don't get the response you want, call a genetic counselor. They can help you get a referral. And this is just another example of breast cancer can affect males as well as females. This is Matthew Knowles, who's Beyonce's father, and he talked on Good Morning America about the fact that he was diagnosed with breast cancer and talked about his cancer diagnosis and his journey. And so this was enough to seek genetic counseling and testing, because male breast cancer is one of those risk factors that could indicate a higher risk of having the BRCA1 or BRCA2 genes. So again, both sides of the family, males and females. And then here's a quiz question. True or false, genetic testing costs thousands of dollars and insurance usually won't pay for it. So 1 is true and 2 is false. Good. I'm seeing a lot of falses, and that is correct. Genetic testing costs are covered by most health plans when people have health insurance. And there's certain, for even like Medicare and Medicaid, there's certain criteria that if a family meets that criteria, that testing is covered. It's guaranteed that it'll be covered. But most people can get testing for $250 or less. And then tests like Ancestry DNA tests or 23andMe, sometimes they will offer very limited testing for hereditary cancers. And we do not recommend that you make any medical decisions based on direct-to-consumer testing. It's just better to go through a provider, and it's better to make sure that you're getting the right test for your family history than a more limited test through one of these companies. So our recommendation would be to talk to your doctor or to see a genetic counselor if you're interested in genetic counseling and testing. And you can find a genetic counselor at the National Society of Genetic Counselors. You can look at that QR code or just go to nsgc.org. And you can find a list of cancer genetic counselors around the country. There is now opportunities for telephone and telemedicine genetic counseling. So if you don't live near a genetic counselor, you can still access services. Okay, another quiz question. If you test positive for an inherited mutation linked to cancer risk, there's not much you can do about it. Good. I'm seeing a lot of falses, and that's true. There, as you've heard from our speakers and you've heard today, there are many, many things that you can do to manage that risk. And so finding out is the first step to taking those actions. And I'm going to hand it on to Juanita.
Thank you so much, Angie. Appreciate this conversation we're already having. There's been so much information shared that's been helpful, and truly this is about empowering yourself and empowering your family and knowing the steps that you can take and being aware of some of the resources available to you. So the first thing that we want people to know is what we've already been talking about, knowing your risk, having that conversation, and we understand that that can be challenging, and we will share resources towards the end of this presentation, but being able to have the conversation so that you could have more knowledge of your family medical history. And of course, knowing the symptoms. You know your body best. So as we're sharing that you should be advocating for yourself, you know what's the norm for you, but also be aware of the symptoms that are common with many of these cancers that we've discussed. And we'll be able to share a few more details in the coming slides. Screening and detection. This is an option where screening and detection is to find cancer at its earliest and most treatable stage. And we want to make sure that people are aware of the screening and detection methods so that they can have any questions answered and also have the information so that they can take the necessary steps if they need to be screened. And lastly, prevention. This can involve taking a medication to lower risk. It can involve having a surgery if that is the appropriate choice that is made with the care team and the individual. And in some cases, there might be a vaccine that can be available. So we're going to go over some of the common hereditary cancers and a little bit more that you can do as it relates to some of these steps here that you see on the screen. So I'm going to pass it off to Verinda, who's going to chat with us about breast cancer screening and prevention methods.
Thanks, Juanita. So on the screen, you'll see breast cancer. We have screening and prevention in the boxes there. And just for most people that are at high risk for breast cancer, there are options for enhanced screening. Women and men with increased breast cancer risk should have a breast exam by their doctor. They should report any changes in their breasts to their doctors, and this is known as breast awareness. Mammograms are important for high-risk women. The recommended age to start mammograms in high-risk women is younger than for average-risk women. The age depends on the gene, and depending on their risk, some experts also recommend mammograms for high-risk men. Breast MRI is also recommended for high-risk women. It can detect smaller changes in the breast that might indicate cancer. There are also options such as medications or surgery to lower the risk for breast cancer in women at high risk. And several groups of researchers are developing vaccines to prevent cancer, breast cancer. Now I'm handing back to Winora.
Thank you. Now, colorectal cancer has a few options when it comes to screening, but the most thorough screening option is the colonoscopy. And you may notice that colonoscopy is listed in both screening and prevention box. This is because colonoscopies allow doctors to find precancerous polyps and remove them before they turn into cancer. The other tests can alert your doctor to possible presence of cancer, but in the event the test results are abnormal, they are followed up with a colonoscopy. For prevention, in addition to colonoscopy, aspirin has also been shown to lower the risk of colorectal cancer. As I mentioned earlier a little bit in my story, how for me, my preventive measure is taking a yearly colonoscopy test. And this has proved to be life-saving for me. And in addition to that, I want to point out that there are preventive vaccine research studies right now enrolling people with Lynch syndrome. This is my second year participating in the phase 2 Triad 5 vaccine study or clinical trial, which, if it is as successful as they think it will not only prevent me from getting future cancers, but my children and grandchildren who have a 50% chance of being Lynch syndrome positive as well, will have an opportunity to take a vaccine that is preventive in nature, possibly eliminating future cancers for them as well. Next slide. Now, one of the most important ways that people can protect against endometrial cancer is to know the symptoms of endometrial cancer, which are listed on this slide. The most common sign is abnormal vaginal bleeding. FORCE is a partner along with the advocacy groups SHARE, ICANA, Black Health Matters, the Ovarian Cancer Research Alliance, and with the company EZI on a campaign called Spot Her, which is all about raising awareness of endometrial cancer symptoms. And now I'm going to pass it along to Junius.
Prostate cancer is the last one that we're going to talk about here. It's imperative for all men to know the risk of prostate cancer. Age is an important risk factor. African American men are at a higher risk for getting diagnosed with prostate cancer, and it's more likely to be at a younger age and a more aggressive form of the disease. Genetics also plays an important role. Even if you have no prostate cancer in your family, it's imperative to know that many of the mutations we mentioned in this talk, like BRCA and Lynch syndrome, can increase the risk of prostate cancer. Especially with the mutation in BRCA2, the cancers tend to be more aggressive, requiring treatment. Even without a mutation in the family, having a family history of prostate cancer can increase your risk for having the disease. Increased weight has also been linked to an increased prostate cancer risk. It's important to speak with your doctor about prostate cancer screening. There is a perception that prostate cancer is a slow-growing cancer that isn't dangerous, and sometimes that is true. Because of that perception, some men may decide not to have screening. But unfortunately, prostate cancer can be aggressive, and especially in African American men with mutations. Screening usually starts with a simple blood test known as a PSA test. So it's important for men age 40 and older to talk with their doctor about prostate cancer screening. Please get tested. Talk to your relatives about your family health history. We talked about that earlier. I think that if you leave with nothing else, hopefully that resonates in your minds and hearts that conversations have to occur. Well, Nora, I don't know if this gets turned back over to you, if you guys want me to.
It's from me. I'll take it.
I'm sorry, Angela.
No, you're no problem.
Okay, thank you, ma'am.
Sure. And it can be hard to talk to your family or know how to have these conversations, and we recognize that. And I also want to say that once you've had that conversation, it's not up to you to make sure that they act on it. Your responsibility, if you have this in your family, is to try to get that information out to others, knowing that not everybody's going to use that information in the same way. But there are some resources that can help with these conversations. There's a simulation that the CDC, the Centers for Disease Control, has that's called Let's Talk, that helps you walk through what those conversations might look like. There's the Genes Between Us, which are tips for informing family members about the genetic information. And that comes from Force. And then there's Reverse the Curse, which is a journal and coloring book of encouragement for women fighting hereditary cancer. So use those resources and similar resources to help you having those conversations. And then another poll, if you test positive for a genetic mutation, you could lose your job or insurance. I know somebody asked about this already in the chat, but true or false? I'm seeing a lot of falses, which is good. If we go to the next slide, there are federal laws. The GINA law is the Genetic Information Non-Discrimination Act. And then there are state laws in almost every state that protect people from losing their health insurance or their job based on a genetic disease risk. They all have different limitations and benefits that are related to different factors like how many people are employed by the company that you worked with. And the laws have some gaps, but in general, those laws protect people against genetic discrimination. GINA has been in place since 2008. That's when it passed. And then in 2009, it went into effect. And that bans genetic discrimination in health insurance and employment. It does not apply to life, long-term disability, or disability or long-term care insurance, though. So if somebody's thinking about genetic testing or genetic counseling, they might want to consider getting those types of insurances before they have any test results. There are some additional exceptions, including for active members of the U.S. military that are not protected by GINA. And some states, like I said, have laws that offer additional protections. And so if you see a genetic counselor, they will update you on the laws in your area and can tell you what some of the limitations are that might be relevant to you. And I know somebody asked about, with the current administration, is this going to change? Since there's so many state laws in addition to GINA, and because they're laws, it's going to take some time if there's anything that's going to happen for these laws to be, if somebody were so inclined to overturn these laws.
Thank you so much, Angie. And thank you to all of our speakers. Stick with us. We're going to wrap up on this slide, but there's additional slides that we have with resources. And of course, we're going to have our question and answer. But first, we just want to leave with the message that you can take action, and kind of highlighting some of the points and circling back on our goals for today and what you will be able to take away after this webinar. So of course, we want to reiterate the message of the importance of talking about your health history with your family. And we saw in that poll that there's differing aspects for everyone. Some people know their family medical history, some people don't. But regardless, we should be making sure that we can have the conversation or start the conversation utilizing the resources we discussed earlier and what we'll share in just a moment. And also knowing your risk. So being a part of the conversations with your doctor and considering and talking about the options related to genetic testing and or counseling, and being able to have a conversation about any cancer screening guidelines with your physician that you should be following based on your family medical history and your medical history. Of course, Force and other organizations have resources that are available to you and help families with higher risk of hereditary cancer make decisions about their care. Of course, you can always visit our website for more up-to-date information. And I'm going to go to the next slide to show where you can connect with Force, because we shared quite a bit of information today, and there might be more that you want to have. In the chat, we will make sure to share a link to a resource where you will be able to click on various information, and I will actually show it now. You will be able to see a link to this resource so that you can have this information. And it's just broken out with resources based on genetics, screening and prevention, and sharing information and having conversations with your relatives. We want to make sure that you are able to print this or have this accessible to you after this webinar. So I'm going to go back to our slides, and I'm going to open it up to our comments and our questions. And very quickly, I'm going to open up the chat now that we can see what questions individuals have. And really quickly, for any of our panelists, were there any questions that stood out to you that you wanted to make sure were addressed? Feel free to unmute and share that while we go back.
Somebody asked, oh, sorry.
No. Go ahead, Angela, please.
Somebody asked, are there separate tests for different types of diseases, or will the same test cover all diseases? And both. It really depends on what you're looking for. There are tests that look for certain, like genetic risk factors for breast cancer. There's a panel of different genes on that test. But there are also tests that will test for all of the genes within the limitations of what we have currently with the technology. And so what type of testing is ordered depends on the circumstances for which somebody's referred for genetic counseling and testing. Go ahead, Winora.
Thank you, Angie.
Thank you. I was just going to also add that having a really good relationship with your doctors is probably important to all of us, but self-advocacy is so important. So I know for me, for years, I would go and sit into my doctor's office, and the first thing they do is they turn around, they ask you, they say, "How are you doing today?" And I would say, "Okay," not sharing with them that I really wasn't okay that day. So it really starts with being honest and upfront with your providers, your healthcare providers, and then telling them what you want, what you need. If you feel that or know that you have this family history of cancer and you want to be tested, make sure that they know that you want to be tested. It really is life-saving.
And I will add, just very quickly to kind of piggyback off of some of these conversations, there are going to be some families where individuals just aren't ready quite yet. Don't give up on that family member. Eventually, they will want to be open to a conversation and sharing a little bit more. It can be challenging. So that's why we want to make sure that you have access to these resources. And Sue had put a link into the chat. Thank you, Sue, to those resources so that you can have that printed off or shared with your family. And I see a question here that's coming in. How is it determined that a variant of unknown significance result is actually benign?
I can take that one. And there are scientists that look at the specific change in a gene, and they look at what's known about that gene and what's known about the position in that gene and how that might affect the protein that's made from it. And using that information and then information from any other labs that might have found that same variant in other families and the family histories linked to that change. That's how there's a whole set of like criteria that the testing labs go through to really assign those variants of uncertain significance and decide at some point they might end up information to call it benign or something that's pathogenic. And so they have to go through all that criteria. And sometimes they have to wait till more evidence is available to know for sure how to assign that. But it's a systematic process by which they do that. And because genetics testing is still relatively new, sometimes we don't have all the information we want about what a change in a gene means. And sometimes it just takes time to figure out what that means, which is frustrating, I know, for families.
Thank you, Angie. And I do want to make sure that we get to our survey and that you're able to see that. Panelists, were there any questions that I might have missed in the chat as I was scrolling? I believe we've answered them through some of the slides, but just want to double check.
I think Tamika, if I'm pronouncing it correctly, asked, do you have to go to a specialist for testing or can you see your primary care doctor? And I think it really depends on how up to date your primary care doctor is. If they feel comfortable providing that counseling and testing, you could have that conversation with them. Many times from the primary care physicians I work with, they're more likely to refer you to somebody else because genetic testing is changing so rapidly and they have so much to keep up to date with. Being a primary care physician, it's hard for them to keep up with the genetics, but definitely start the conversation with that individual and ask them if they can help you or if they want to make a referral to someone else.
Thank you so much, Angie. And just to make sure that we get to our survey, and thank you all for being here, I want to make sure we get to this slide. And thank you, Sue, for putting the link to the survey. If you happen to have your phone handy, you can also scan the QR code. But we've shared a great deal of information here, and we want to hear from you. We want to hear additional information that you would like to know, any feedback that you have for us. And of course, we want to thank you for coming. I personally want to thank our panelists for sharing their stories, for being so open about the importance of this conversation and knowing our family medical history. And of course, to Ray for this partnership where we were able to convene and have this conversation that we are recording and we'll be able to share out broadly. But back to Verinda.
Well, I just want to again thank everyone for joining us today and for participating. This is something that we really want to take advantage of at this time, especially the importance of knowing family history and the importance of screenings and the fact that early screenings are really a good defense against cancer and they can catch cancers at an earlier stage. So the more you know about your family history, the more you can gauge your risk. And then we have these resources available for you to be able to get comfort and feel comfortable with the information that you have and having those conversations with family. I know for myself, it wasn't easy, but it was important. And ultimately it's, I think, saved my sister's life was to have the ability to have the screenings and the testing and things like that. So knowledge is power and always be an advocate for yourself. I know someone else mentioned that as well. It is really important, especially now, to be able to speak to your own power and the need for information. If you don't get satisfactory information the first time, there's always other doctors, other resources, other places to check to make sure that you've gotten the information that you feel you need. So thanks everyone for coming. Really appreciate it. And don't forget the survey.